Well, good morning, everyone, and welcome to the Cardiology Grand Rounds today. I'm honored and a great pleasure to introduce Bill Fearon today, who's one of my mentors from Stanford. I want to set a few rules for the day. So any questions in the Q&A section of the presentation. Okay, so I would ask folks to go to the microphone for this. Otherwise, from online, you can use the Q&A function. So it's a great pleasure to introduce Bill. So Bill's originally from the East Coast, completed medical school at Columbia before moving to the West Coast, and he's been at Stanford ever since. He's now full professor of medicine at Stanford. He's the chief of interventional cardiology at the Stanford Hospital, also the chief of cardiology at the VA Palo Alto. His main research interest, you'll most likely know, is coronary physiology. So he's co-authored over 350 peer-reviewed publications on the topic, and his work extends from the animal lab all the way to large multi-centered RCTs. So he's invented and validated IMR, which is the index of microcirculatory resistance that we now use commonly in the cath lab. He's also the PI of the FAME trials that have impacted the practice of interventional cardiology. On a personal level, Bill is a very humble and approachable person, which makes it a joy to work with him as a trainee. It was really a privilege for me to work with him at Stanford during fellowship. So I'm very glad he accepted our invitation to come to Ottawa today to present Grand Rounds, and I'm sure you'll find the presentation today to be thought-provoking. So please join me in welcoming Bill Fearon.
Great. Thank you, Pascal. It's an honor to be here and a privilege to present. I'm going to talk about PCI versus CABG, the ongoing feud. These are my disclosures. And in preparing this talk, I got to thinking about some of the great historical feuds in America. And those of you who've gone and seen Hamilton, the musical, are aware of the feud between Alexander Hamilton and Aaron Burr, and how it culminated in a duel with Hamilton shooting in the air and Burr shooting and killing Hamilton. There's also a historical family feud in the United States, the Hatfields versus McCoys in the late 1800s that led to numerous deaths. And we have more recent feuds between Pepsi and Coke. And my kids try to explain to me the rationale for the feud between Taylor Swift and Kanye West. But there is, of course, a most recent feud. And as an American coming to Canada, this was immediately apparent to me. And I was a little worried that Pascal may rescind his offer. And that's, of course, our president and his courting of Canada and Canada's response to that. And so I was worried, but then I remembered, well, I'm a Californian and we're already part of Canada. So I don't think I have to worry anymore. And so, again, thanks for the invitation. As far as the feud between PCI and CABG, I think this had its origins back in the late 1990s. This trial, the Berry study, is something that's near and dear to our hearts at Stanford because one of my mentors, the late Ed Alderman, was one of the PIs of the Berry trial, and a current collaborator, Mark Latke, was also very involved. And this was a study looking at PTCA, or angioplasty, versus CABG in 1,829 patients with 2 or 3 vessel disease. And the primary endpoint shown here is the 5-year survival. And you see that there was no statistical difference, but there was a trend favoring CABG. The other thing I want to point out is just the absolute numbers of 5-year mortality, because we'll come back to that when we talk about more current data. Importantly, when you looked at diabetics, there was a much more dramatic difference and much higher event rates in both groups. And also remarkably, if you look at the repeat revascularization rate, it was 55% in the angioplasty arm. And again, keep that number in mind and we'll see how things have changed. There was next a large meta-analysis, 10 randomized trials. This was comparing bare metal stents and angioplasty to bypass in over 7,000 patients. And there was a trend favoring CABG with respect to survival and no real difference in death or MI at longer term follow-up. However, again, we see this discordance in event rates when you look at diabetics. So the PCI patients did much worse than bypass patients. Both, of course, did worse than non-diabetics. The first drug-eluting stent trial that we're all familiar with is the Syntax trial. This included 1,800 patients with three-vessel disease or left main disease and randomized them to PCI with the Taxus, or the first-generation drug-eluting stent, versus CABG. About a third were diabetic. There were a large number of stents and a long length of stents. It was a very aggressive stenting procedure. And about 1,100 of them had just three-vessel disease, not involving the left main. And I'm going to focus a little more on that group because those are the patients that we included in the FAME-3 trial. And in Syntax, if you look at the 5-year death, stroke, or MI rate in those patients with three-vessel disease, you see that there was a significant reduction in the event rate with bypass compared to PCI. Even if you just look at death alone, there was a 5% reduction, absolute reduction in all-cause death with bypass surgery. But some people say, well, those are randomized trials, select populations. We should see what's happening in the real world. The ASSERT registry was a large study, almost 200,000 patients who are over 65 years old and were treated either with PCI or CABG. This was mostly first-generation stents, drug-eluting stents, and versus CABG. And you see that there was a significant reduction in mortality with bypass compared to PCI. Now, this wasn't randomized. The investigators did propensity matching to try to account for differences, but you never know for sure if they were all accounted for. But so far, everything is looking in general like it's favoring bypass surgery. So what's changed since then? Well, stent technology has evolved. FFR-guided PCI, or using coronary physiology, has been shown to improve outcomes compared with traditional angio-guided PCI. And we've learned a lot and gained greater appreciation for the importance of medical therapy, both after bypass as well as after PCI. So how has stents evolved? Well, the first generation DES included the Cypher or the Taxus stents. These were sirolimus or paclitaxel coated. They had thicker struts. They were made out of stainless steel and had a thicker polymer coating that was durable and somewhat inflammatory and led to late complications. The current generation or second generation DES are stents like the Xience or Resolute or Synergy that you may be familiar with. They have everolimus or zodorolimus coating, thinner struts, cobalt or platinum chromium, and a thinner polymer coating, and they're more biocompatible. So we see lower rates of late complications. And in fact, when you look at randomized comparisons, this is the everolimus versus paclitaxel stents, you see lower rates, in this case of myocardial infarction at 3 years. And if we look at just all-cause mortality, that's also significantly lower at 3 years with the second generation DES. What else has changed? Well, we've now appreciated that fractional flow reserve improves outcomes. This, for those who aren't familiar with it, is measured in the cath lab, typically with a pressure wire, where the pressure sensor measures the pressure beyond the stenosis, and we compare that to the pressure measured with the guiding catheter. And we give a medication like adenosine to increase blood flow and simulate stress or exercise, and look at the peak flow or maximum flow and look at the gradient. And in this little case shown down here, the mean pressure distally was 60 and the proximal pressure is 100. So the FFR is 0.60. And what that means is that 60% of the blood that should be getting to that part of the heart is actually getting there. And we've learned that anything below 0.80 correlates with ischemia and also identifies plaques that are likely to cause events and benefit from PCI. Whereas if it's above 0.80, those lesions can be safely treated medically generally. And so the first big trial to evaluate using FFR to guide PCI was the FAME-1 study. This was 1,000 patients with 2 or 3 vessel disease. And they were randomized to the traditional strategy at that time, which was, looking at the angiogram and just saying, well, I think that's an important lesion. That one I think we'll leave alone, and stenting based on that, as well as any clinical data that you had. Versus using FFR, where you measured FFR in each vessel with a lesion, and only if it was significant did you place a stent. And what you see is that at 1 year, the MACE rate as well as the death and MI rate were lower in the FFR-guided group because you eliminated or avoided unnecessary stenting and the complications from that, and only stented lesions that really needed it. Now, one of the sort of themes that emerged from that study was this idea of anatomic versus functional coronary disease. And so in FAME-3, there were a number of patients FAME-1, there were a number of patients that had 3-vessel disease based on the angiogram. But after you measured FFR, you came to appreciate that really they had only single or double vessel functional disease. And that can simplify your procedure. We can also use those data to calculate what we call the functional syntax score. The syntax score, is an anatomic score that basically rates the complexity of the disease based on the angiogram. And so we did that in FAME-1, where we broke patients down into the high, intermediate, and low syntax scores without FFR. And then we took into account FFR, and if a vessel or a lesion had a negative FFR, then you subtracted that and you calculate a functional syntax score, which not surprisingly shifts about 1/3 of patients from a higher to a lower risk category. The reason that's important is that we found that functional syntax score was a better predictor of outcomes, death or MI in this case, compared to the classic syntax score. So you see that there's a higher proportion or the high-risk patients have a higher event rate, and there's a fewer number of them, and the lowest risk group has a significantly higher number of patients. So again, we've shifted the patients to a lower risk group and better stratified them. So FFR identifies lesions which are not hemodynamically significant and respond well to medical therapy alone. This avoids the acute and long-term risk of unnecessary PCI. And it also identifies lesions which are hemodynamically significant, where the benefit of PCI outweighs its risks. The last thing that we've learned is about the importance of medical therapy. And this is just one example. These are data from the Syntax trial, where they looked at 5 years, those patients who were on optimal medical therapy versus those who weren't. And this is both, again, PCI or CABG patients. Unfortunately, only around 1/3 of patients were on optimal medical therapy. But what you see is that those groups had significantly lower death rates, as well as death, stroke, or MI. Again, informing us that the procedure, it doesn't end at the end of the procedure, that we have to continue to take care of these patients. So with that background, the objective of the FAME-3 trial is to compare FFR-guided PCI using a current generation DES with contemporary CABG, both in conjunction with guideline-directed medical therapy. And I'd like to show a case presentation. This is a 53-year-old man with typical risk factors: hypertension, dyslipidemia, tobacco use. He was admitted at Stanford with chest pain. He was at work, and he developed some left-sided pain when he was walking down his hallway, described as a burning, lasted about 5 minutes. His coworkers were concerned enough that EMS was called, and he was brought to the emergency department. He was hypertensive, but otherwise had an unremarkable exam. This was before we were using high sensitivity troponins, and his troponin was just at the upper limit threshold of abnormal. He had a normal hemoglobin A1C, and his LDL was 142. So his ECG shown here, he had some ST segment depression kind of laterally and a little bit of poor R wave progression, but nothing too dramatic. So he basically was a non-STEMI. And the treatment options, of course, if he had stable coronary disease, it would be appropriate to focus on medical therapy. And if he failed that, consider revascularization. But this wasn't a stable setting. This is someone with a non-ST elevation ACS. The most recent guidelines just published this year suggest an invasive approach in this type of patient. So we brought him to the cath lab, and you see that he has a fairly high-grade proximal LAD lesion. His circumflex also has a proximal lesion, and then an obtuse marginal branch has a pretty tight lesion. And then his right coronary is very tortuous and has a number of kind of moderate to significant looking lesions as well. And so we have a young man. He doesn't have diabetes. He's presenting with ACS and 3-vessel coronary disease. And so what's the best strategy? Should we do PCI, or should this patient have CABG? And so the guidelines suggest that in this type of patient, it should be based on the disease complexity and the patient's comorbidities. So we'll talk a little bit about our approach at the end, but first I want to go through the most recent data we have, and this is the FAME-3 trial. This is an investigator-initiated, multi-center randomized study taking all comers with 3-vessel disease not involving the left main. There were 48 centers in Europe, North America, Australia, and Asia. And patients were randomized 1-to-1 to either FFR-guided PCI or CABG if the heart team felt that both options were feasible. The primary endpoint was major adverse cardiac and cerebral vascular events, so death, MI, stroke, or repeat revascularization at 1 year. There were pre-specified key secondary endpoints at 3 and 5 years, just including death, stroke, or MI alone. This was a non-inferiority analysis. The study was sponsored by Stanford, funded from research grants from Medtronic and Abbott. We had an independent clinical events committee and DSMB, as well as statistical analysis at Stanford. And this slide shows the baseline characteristics. So these were mostly middle-aged white men with typical risk factors. About a third had diabetes, 40% presented with an acute coronary syndrome. When we look at procedural characteristics, not surprisingly, the time to the procedure and the duration of the procedure were shorter with PCI. The number of lesions was similar, about a little more than 4 in each group. About a fifth had at least one chronic total occlusion, and 2/3 had a bifurcation lesion. So they were fairly complex anatomy. The average syntax score was 26 in both groups. As far as procedural characteristics, FFR was able to be measured in 82% of patients. It was negative in about a quarter of those. Patients received 3.7 stents on average, and the intravascular imaging was used in only 12%. As far as the CABG group, there were 3.4 distal anastomoses, 25% had multiple arterial grafts, and the vast majority had edema. About 25% had off-pump surgery. So again, the primary endpoint of the original study was the 1-year rate of death, stroke, MI, or repeat revascularization. And I think many of us are familiar with the results. PCI had an event rate of 10.6%, and CABG was 6.9%. So PCI did not meet the criterion set for non-inferiority. And one of the questions that came up was, well, was PCI really contemporary? And I would argue that it was for the most part. I mean, most patients had a radial approach. We used current sort of peri-procedural and post-procedural pharmacology. Again, we used a modern day stent. Physiology guided the procedure. The CTO approach was fairly up to date. 20% had CTOs, 61% had an attempt, and there was an 88% success rate. The one issue, though, that I mentioned, only 12% of patients had intravascular imaging. Now, there was a recent network meta-analysis highlighting the benefit of intravascular imaging and guiding PCI and leading to lower rates of death, MI, or target lesion revascularization. But it's interesting when you look at data. So this is 22 randomized control trials, almost 16,000 patients. Right around the same time, there was another meta-analysis published in Circulation that was 24 randomized control trials and almost 16,000 patients as well. And they came to sort of a different conclusion. There was still a benefit with reduction in TLR, but not with MI. And it just kind of highlights how, depending on how you look at the data, you can get different results. And then the Illumium 4 study, which was the largest North American randomized study comparing OCT guided PCI with angio-guided PCI failed to meet its primary endpoint. So I'm a believer in imaging and use it during PCI, but I think these studies do raise some questions about whether you can blame the quote unquote failure of PCI on the lack of intravascular imaging or not. Now, we did learn some other interesting things, I think, from the original one-year data from FAME-3. This is a comparison of the primary endpoint with the syntax trial. Shown here are the rates of PCI and CABG in syntax. And when you look at FAME-3, you see that both groups performed favorably compared with CABG. In fact, we modeled FAME-3 on the syntax event rate, and if that had happened, we would have had similar and probably met non-inferiority, but importantly, CABG has gotten better over time as well. The other thing we looked at was the incorporation of FFR. And so if you look at the syntax score in FAME-3, about a third of patients fell into that low syntax score group and 2/3 into the higher intermediate risk. When we incorporate FFR, we can pull out some of those higher intermediate risk that are actually lower risk based on the functional syntax score and identify half the patients that have a low functional syntax score. And the reason this is relevant is because when you look at the low functional syntax score group, they have a very favorable outcome. This is including repeat revascularization with CABG at 1 year, whereas it's the high functional syntax group that does poorly. Now we've, like I mentioned, had a key pre-specified secondary endpoint of death, stroke, or MI. So moving away from using repeat revasc as an endpoint. And there was no significant difference at 3 years, although there was a trend favoring CABG. And this was due primarily to a lower rate of MI. Death was identical and stroke was slightly lower with PCI. So it was mostly due to myocardial infarction. When we look at the 3-year outcome of death, stroke, or MI and divide it based on the functional syntax score, the half of the patients with the low score perform quite favorably. And again, it's the higher, more complex patients where CABG really has its benefit. We've also looked at some other important subgroups, women versus men, shown here at 3 years. And this is death, MI, stroke, or repeat revasc. The women who receive PCI are shown here in solid red, and CABG are dashed red. And you see that they actually have very similar outcomes and similar to men undergoing PCI. And it's really the men undergoing CABG who benefited the most from that procedure. When we look at diabetics, there was no significant statistical interaction. Both CABG and PCI diabetic patients did worse, but you can see there's a clear separation like we've seen in previous studies with regard to the benefit of CABG over PCI in diabetics and not seen as much in the non-diabetic group. And also, if you look at the survival rate, and I remind you back at the Berry data from 30 years ago, where the survival rate was like, or the mortality rate was like 34% in PCI and like 19% in CABG. You see how much better things have gotten. And there was no difference in death, all-cause death between PCI and CABG. As far as CTOs, some said, well, maybe if you'd been even more aggressive with CTOs, you would have had better outcomes. This looks at the comparison of PCI versus CABG in those patients who had a CTO and those who didn't. Presumably those who had a CTO might get more complete revasc with CABG. And if anything, the differences are slightly less. I mean, again, there was no significant interaction, and the overall event rates might have been a little lower too. And I think it gets interesting when you look at just patients undergoing PCI and those who had a CTO versus those who didn't. You see that actually those who had a CTO had a slightly lower event rate compared to those who didn't. And when you look at why that is, they had fewer myocardial infarctions and also fewer repeat revascs. And the sort of simple way that we explain this is, well, they have one less vessel that could potentially have an MI or have a repeat revasc. And so, or you could say that the people without a CTO have one more vessel or more areas that could potentially cause a problem. I'm not sure if that's true or not, or if that's the explanation, but in any case, I think it argues against, that if we had been more aggressive with CTOs, we might have had better outcomes. And then finally, I think the ACS subgroup is an interesting one. What you see on the left-hand panel is patients, there were about 40% who presented with an ACS, and the event rate between PCI and CABG are very similar due to a higher early event rate in the CABG group. And it's the stable patients who tend to do better with CABG over PCI. We've looked at quality of life at 3 years. It was similar based on the EQ-5D summary score between PCI and CABG. And quality adjusted life years were also similar, maybe a little bit better with PCI because there's, of course, a quicker recovery from the procedure. Costs, not surprisingly, are much lower early after PCI. And there's a little bit of a catch up over time because of more repeat revasc, but overall, there's still a significant difference in costs at 3 years. And so when we calculate the incremental cost effectiveness ratio, in fact, more than 90% had lower costs and higher quality adjusted life years with PCI, and 100% of the simulations, bootstrap simulations, showed PCI to be cost effective with a cost effectiveness ratio less than 50% or $50,000 per quality adjusted life year. So now to the 5-year data, we just presented these at the ACC. We had 95% follow-up that was similar in both groups of patients at 5 years. And the medical therapy was quite good. Around 90% were on at least one antiplatelet agent, and probably some of the others were on an anticoagulant for AFib. We didn't have those data recorded. More than 91% were on a statin, more than 70% on a beta blocker, and more than 70% on an ACE inhibitor or ARB. And there were no major differences between the two groups. So the primary endpoint at 5 years, again, was pre-specified. It was just death, stroke, or MI. And interestingly, we saw that there was no significant difference. It was about 16% in PCI and 14.1% in bypass. And this is different from Syntax and other trials, which had really shown a late accrual of benefit with CABG. When we did a landmark analysis, restarting the clock at 1 year, there was no significant difference in outcomes. So all of the difference was early on during the first year. When we look at the components of the primary endpoint, all-cause death was identical between the two groups at 7.2%. Stroke was slightly lower, about 1% lower with PCI. MI was higher, 2.9% higher with PCI. And repeat revascularization remained significantly higher. And the composite of death, stroke, MI, or repeat revascularization was also higher. Now, another thing that, not getting too into the weeds, but that's important to think about when you're looking at studies is how things are defined. And there's been a lot of controversy about definitions, particularly with regard to procedural myocardial infarction and what's relevant or not. We used the sort of universal definition, which I think was appropriate. There is this other definition, the SKY definition, which is a more liberal definition and incorporates more procedural MI. It has been validated prognostically. If we applied that definition, we'd have much higher event rates in both groups. And you see that, if anything, it would have favored the PCI arm. As far as subgroups at 5 years, there were no significant interactions except with the Syntax score. And you can see that low Syntax score patients tend to do better with PCI, whereas intermediate or Syntax score do significantly better with CABG. And then it's important to compare, I think, FAME3 with the Syntax trial itself. The baseline characteristics were quite similar. Age, the sex, the risk factors, the number of lesions identified, the Syntax score, all were pretty similar between the two trials. But you see that the event rates were quite different. This is death, stroke, or MI at 5 years. Again, Syntax showed a strong difference favoring CABG, whereas, as I just mentioned, we didn't see a significant difference in FAME3. And just death alone also has changed. Mortality has decreased in both arms, particularly in the FAME3, or sorry, in the PCI arm in FAME3, as you can see here. So let's get back to that case I showed you. This 53-year-old man, a young man, admitted with an acute coronary syndrome, and he was included in FAME3, and he was randomized to FFR-guided PCI. And so, not surprisingly, his LAD was highly significant. The green line represents the distal pressure. The red line represents the aortic or proximal coronary pressure. And you see the ratio 0.57, so well below 0.80. So he had stenting of his proximal LAD. We then measured the FFR and his circumflex. It was also, not surprisingly, based on the angiogram, quite abnormal. And so he had 2 stents placed in his circumflex system. And then thankfully, the right coronary was not significant because we were not excited about that tortuous right. And so it was 0.88 above that cutoff. And despite the angiographic appearance, we've learned to be comfortable leaving those lesions and treating them medically. And we can, in fact, in this case, recalculate. So the syntax score was 28. Taking this into account, the functional syntax score decreases to 15. So if you think about this patient and what factors might favor CABG or PCI, so the lower functional syntax score, as I mentioned, kind of makes PCI more equivalent to CABG compared to high functional syntax score. He's a man, so that would favor CABG based on our data. He doesn't have diabetes, and he was presenting with an ACS. So sort of, I guess more of the categories put him in an equivalent strategy. It turns out he's followed up with me in clinic for the past 5 years, and he's had no intervening cardiac events. He's feeling well and able to walk 3 miles without symptoms. So that right coronary has responded well to medical therapy. He's on an excellent medical regimen with decent blood pressure control and lipid control. So to conclude, PCI versus CABG, the ongoing feud. With the evolution of PCI, DES, coronary physiology, imaging, pharmacotherapy, and CABG, as well as medical therapy for coronary disease, outcomes have improved after both types of coronary revascularization. The differences in outcomes between PCI and CABG have narrowed dramatically compared to historical controls. And there are particular subsets of patients who appear to benefit more from one therapy over the other. And so I think discussion with patient and family regarding these data can allow for a shared decision about which treatment makes the most sense. Thank you for your attention.
Thank you so much. That was a fantastic presentation, Bill. Maybe I'll start with a first quick question for you. So I'm sure you're well aware of some of the criticism about the change in outcomes between the initial trial at 1 year and the 5 year. So can you comment on the rationale for that?
Yeah, so thanks, Pascal. So that has raised a lot of concern, I would say. The fact that we included repeat revasc at 1 year and then didn't during longer term follow-up in our primary endpoints. This was very carefully considered. We had a steering committee that included both cardiologists and cardiothoracic surgeons, and we agreed that our primary goal of the study was to compare it to syntax. And syntax used a 1 year endpoint, which many can argue is way too short. And it also used repeat revasc as part of the primary endpoint, which others would argue is not appropriate. But we wanted to do that so that we had as least variables as possible. And really the only thing that was changing was the incorporation of physiology and new stents. And so that's how we established the 1 year endpoint. But thinking about that, we knew that longer term follow-up was critical. And also we wanted to focus on what we thought were more hard endpoints. Now, repeat revasc, some would argue, is not really an endpoint. It's a decision. Physicians decide whether or not to do it or not. And it may be biased because studies have shown that interventionalists are more likely to bring PCI patients back to the cath lab than they are CABG patients because they're considered less complex. So that's one issue. The other issue is that repeat revasc has evolved as far as like its prognostic importance, and it's may not be that relevant an endpoint as far as predicting further problems. And many patients, view it as a minor thing because it's often same day, you go through the wrist, it doesn't have the same implications as it did previously. So for all of those reasons, we thought that it was fair to eliminate it. And you could argue that there's other things like rehospitalization or bleeding or atrial fibrillation, which have been shown to predict worse outcomes if they occur in patients and tend to occur more commonly after bypass, that those should be part of the endpoint or just as equally as repeat revasc. So I understand the criticism, and I mean, the primary endpoint was 1 year and PCI failed to meet it. So any further testing of the data, you have to view as like hypothesis generating. And so, we can't rely on it completely, but I think it's informative. And our hope, I was saying Ongoing Feud a little tongue in cheek. I mean, we work extremely closely with our surgeons. We have a heart team meeting. We discuss these patients. There's clearly patients who surgery is the best pre-treatment. And I think there's others where you can get a good result with PCI. And we just try to explain that to the patient and help them decide.
So Bill, thank you for a very insightful talk and your leadership in the field. And certainly I think we've all learned a lot from this. I think one of the concerns that we often have in terms of these PCI versus CABG studies is biases within individuals prior to randomization. So that interventionalists, if I see a DC3 vessel, I'm going to pick that off. Similarly, severe disease, I'm going to send it to surgery. And certainly even right now, let's say our group screening for stage 3 right now, with a lot of discussion around it, we've not been very successful in terms of randomizing because of these biases. Do you have any insights in terms of whether there are any differences in terms of referral patterns within centers? So that, let's say, a fifth of your patients had high syntax scores, or there are differences in terms of individual centers that certain ones would have more patients of high syntax versus low syntax, or has that actually been looked at?
Yeah, so it's a great question. We haven't specifically looked at based on syntax score from different centers. We did look at outcomes and geographies, and we didn't see any differences. But I think you highlight an important point. Anytime you have a randomized control trial, it often is a more select population. And I think there were clearly patients who had such complex disease that PCI wasn't even considered, and they went to CABG. And so you have to remember that these data are patients who both the heart team felt could get either approach. So it is definitely a select group, and so it doesn't include those. I would say that we had a little bit of trouble because a lot of the centers participating, or most of the centers, had a lot of experience with physiology and were already doing physiology when they evaluated these patients. And as I showed you, you can convert a lot of patients who have 3-vessel disease to either single or double vessel disease, and then they never even get into the study. So it did work the other way too, that there were probably a fair number picked off that weren't included. And that may explain why the negative FFR rate was only about 25%. Usually, like with intermediate lesions, as you know, it's more like 40% or 50% are not significant. But so most of the lesions were significant, and that was probably because some of those patients were picked off already.
I think we do have a roving mic as well, or do you want?
Sure. Yeah, I have right here. I was standing up randomly.
Waiting for virtual questions as well.
Okay, you have some from the online. Well, Bill, it's wonderful. Really, what a great thing to see you coming, supporting Pascal, sitting him off. I think it's kudos to the interventional cardiology for doing that. I think we should do it every time we have a star fellow coming back on faculty and coming and being sent off, if you will, quote unquote, by their supervisor. So that's a wonderful thing to see. And I hope we see it more often. And thanks for your mentorship of Pascal and others. I have one quick comment and then one very difficult question. So it's interesting that your slide number 4 shows advances in PCI and medical therapy. And then in your conclusion, you did say that CABG is getting better, and you show some data to that effect, but CABG is getting better. As you know, I mean, the first year results of FAME3 were excellent. I think CABG mortality was even better than PCI. Stroke rates were extremely low. It's still remarkable, though, that in a mean age of 65 years old, you only had about 24-25% of patients with multiple arterial grafts and off-pump surgery. I can tell you at the center here, it'd be the complete opposite. It would be 24-25% who did not get multiple arterial grafts. So, very respectfully, I would venture that, one of the greatest correlations in medicine is between the leadership of the trial and the desired primary outcome, having a correlation of a significant p-value, if you will, with regards to primary outcome. So I know we both know Mike Reardon and Joe Wu very well. They're not CABG experts, right? FAME3 was kind of for surgeons, I think, a bit of an afterthought. Like Ann Young was closely involved, and then I think the few patients within FAME3 go, well, what is that thing, right? 5 years ago, and we kind of did it. So I think maybe, again, the concept of co-leadership of trials with real expertise on both sides is something, in my opinion, that cannot be overstated. And again, kudos on FAME3. My question for you, very difficult, and maybe we can talk about it. You're probably one of the best positioned people in the world to answer a very difficult question that we surgeons have. What is complete revascularization of that surgery? And you now have a wealth of data of patients who have FFR values, most often, and rightly so, not being used to determine whether they would put a graft on that second marginal in addition to the first. But now you have 3.4 grafts. You have a number of FFR values, which were not followed. And you probably have follow-up data for 5 years. That is such an important question. What happens to that FFR negative artery that was not or was grafted at the time of CABG? And frankly, we don't have the answer. And I think FAME3 and you are probably the closest thing to the answer. So I'd love your thoughts. Thank you.
Great. Well, thanks, Mark. And again, it's great to be here and to be able to reconnect with people like yourself. And it's great to see Pascal again. He, I think, taught us as much as we may have taught him during his time, and he was terrific. And so thank you for sharing him. Regarding your comment about the leadership and all, I think that's a very valid statement. I do think that we had strong recommendations to achieve optimal CABG. And I would say that it was disappointing. I mean, at least in the United States, we actually did better than if you look at the STS registry. It's only around 15% that get multiple arterial grafts, and we got 25%. So we were happy with that, but you're right. I still sort of, we want our patients to get multiple arterial grafts when we send them. So that's something we need to work on, I think, as a group. And then regarding the question about the FFR guided CABG, so to speak, and completeness of revasc, we are looking at completeness of revasc, and we should have a publication coming out soon. It's challenging in the CABG arm for 2 reasons. One, we didn't measure FFR in all the CABG patients. And the reason for that was because a lot of centers would get referrals of patients who had had an angiogram done outside that had 3-vessel disease. And if we were going to mandate FFR, then they would have had to be brought back to the cath lab, had FFR measured, and then they might get randomized to CABG and sort of have undergone an unnecessary procedure. And also the data had and still don't show really that FFR guided CABG is beneficial, which is kind of interesting. And I think it speaks to the fact that there's less of a downside of putting down unnecessary graft as there is in putting in unnecessary stents. Certainly if a stent goes down, you're in big trouble. If a graft goes down to a vessel that didn't really need it, it's not as big a deal. Although people would argue that grafting a lesion that's not significant can be detrimental because there may be progression of disease in the native vessel that occurs. So in any case, unfortunately, only around 10% of patients had FFR data. So we don't know for sure what the impact would be in the CABG group. And also, we don't have follow-up either CT scans or angiograms to look at which grafts are still open. So there's a few holes that limit our ability to analyze. And even doing completeness of revasc is challenging because we're doing it off of the OR reports. And, what's at a diagonal or a ramus or, that was bypassed. Sometimes we don't know for sure if which vessel was bypassed. So it's a difficult but important thing that we need more data on. I agree completely.
I'm going to get one of the online questions and then we'll get to Dr. Bourgain here. So this is from Dr. Shumu. Maybe redundant question. What is the percentage of patients randomized to PCI and FAME3 that had successful complete revascularization?
Yeah, so we're going to present those data. And I think one thing is also how you define, before we even say what the percentage was, is how you define it. You can have anatomic complete revasc where, everything that had a lesion was stented. I would say that that was a lower percentage compared to those that had functional complete, where everything that was FFR positive got stented. And in that case, it was around 60 or 70%. So it was good, but it wasn't perfect. And that was probably because, CTOs that weren't opened were still considered significant. And so that would decrease the percentage. And again, the percentage of complete revasc was higher, not surprisingly, with CABG than PCI, but we haven't completed all the analyses, so we'll have more data about how important that is to get complete revasc.
There's a lot of data emerging about the pattern of disease, focal versus diffuse. Was it looked at in FAME3 whether the FFR pullback gradient is diffuse or focal, how it impact outcomes?
Yeah, so that's a great question. It's referring to focal versus diffuse disease, and sort of classically, people would just put a pressure wire down in the distal vessel. If it's abnormal, then they just go ahead and stent whatever lesions they see. And there's more of an emphasis now on, once you have the wire down and you're giving adenosine, to slowly pull the wire back and sort of create a road map of the disease in the vessel. And that can help you identify focal from diffuse disease. And focal disease, turns out, benefits, not surprisingly, more from PCI than diffuse disease. And you could argue that diffuse disease should either be treated medically or with bypass rather than diffuse stenting. We did not mandate that, and so we don't have pullback data in these patients. We do have post-PCI FFR in about 60%, and that those patients who had post-PCI FFR did have better outcomes. Again, it's not randomized in the PCI versus the PCI patients who did not. But it would have been good if we had done that. Again, this study, this has been going on for 10 years and things have changed over time. And so we don't have everything we want. In addition, we didn't have a robust budget. It wasn't industry sponsored. We didn't have a huge amount of NIH or other funding. So we had to kind of pick and choose what we focused on. And we wanted to make sure that we didn't overburden the sites with a lot of data capture and discourage enrollment.
There aren't any online. Maybe I'll ask one more question. Even in your 1-year data, clearly what you see is that the point estimates for females are different compared to males. And certainly the data that I know now, that there might be a difference between male and female. With recharge coming in right now, looking specifically at female vascularizations, do you have any insights in terms of the pattern of disease between that were within very?
Yeah, so the question about women versus men and the pattern of disease, in both FAME3 and in other studies, what we've seen is that women tend to have fewer significant lesions based on FFR. And so their PCIs end up being less complex. And I think that probably leads to reasonable outcomes in them. And then I think, and I'd be interested in Mark and the surgeons' viewpoint on this, but it seems like the outcomes with surgery weren't as good in women versus men, and maybe they're just a higher risk group and it's more challenging to get them, through the procedure. I don't know, but I think on the PCI side, they tended to have less complex disease, and that probably accounted for good outcomes.
I have one more question for you. What are your thoughts on the use of FFR-guided PCI in STEMI patients for complete revascularization?
Yeah, great question. There's a lot of controversy over the role of physiology in STEMI. The concern being that certainly we don't recommend it in the culprit vessel because there's a lot of transient microvascular dysfunction that's occurred because of the thrombus and inflammation, such that if you measure FFR, you may get a higher value because you don't have complete vasodilation. And then if you bring the patient back, 6 weeks later, once the microvasculature stunning has resolved, you get a lower value. So in the culprit vessel, it's not recommended. The question is, can you do it safely and accurately in the non-culprit? And some have argued that the microvascular dysfunction may be more of a global phenomenon, and you may lead to falsely elevated values in the non-culprit vessels. I think that's still controversial. There was the Flower MI study, which showed no difference in outcomes, and FFR was felt to have failed, although the physiology arm got a third fewer stents and still had the similar outcome. So I'm not sure if it really failed or it didn't have as dramatic a benefit, because in the setting of STEMI, really the thing that drives the endpoints is the culprit vessel and not the non-culprit. But the COMPLETE-2 trial is now ongoing, a 5,000 patient randomized study that's comparing physiology-guided non-culprit assessment versus angio-guided, and we'll see what that shows. I personally think it's reliable, and so I still use it. I think in the setting of STEMI at 3 a.m., the staff aren't always that happy when you want to pull out the pressure wire and start giving adenosine. But fortunately, we do have newer techniques. There's something called angiography-derived FFR or physiology, where based on the angiographic images and computer algorithms, you can basically calculate the FFR and not have to put in a wire, not have to give adenosine, and particularly in STEMI patients, that can be quite useful. And it's been shown to be correlate very well with wire-based physiology. We just finished a randomized study comparing FFR angio with wire-based physiology in all comers, and we'll see if it's meets its endpoint or not.
Fantastic. And as some of you may know, Bill's also a TAVR operator. So I'd like to get your thoughts on the role of PCI in coronary disease that is found incidentally in patients with severe AS.
Yeah, that's a great question. And I think an evolving one. Our approach from a clinical standpoint has been to really only treat those high-grade, proximal lesions and basically focus on the valve, and then, reevaluate patients who have more moderate disease. I think using physiology in the setting of AS is challenging because of the hemodynamic changes that those can affect resting ratios like IFR. We might get a lower IFR initially and then a higher one later. FFR, it's the other way around. Because of the microvascular effects of the AS, you might get a higher FFR early on and then lower after TAVR. So using physiology is a little bit tricky. We do have some data. I think it was the Notion 3 trial showing that FFR-guided approach is beneficial. So I think it's evolving. I think certainly, if you're going to be undergoing surgical AVR, it makes sense to take care of the coronary disease. But in TAVR, I'm not as convinced, and so we take more of a cautious approach. And again, unless it's really high grade, and treat the valve and then reassess the coronary disease after.
Fantastic. Well, thank you. Any other questions from online?
No, there.
Fantastic. Well, please join me in thanking Bill one more time. Thank you so much for being here. about like this. We have a conference. Yeah. Yeah.